Okay. So good morning and good afternoon and good evening, ladies and gentlemen. So thank you very much for participating in the APHOG and SIOP Asia Joint Scientific Symposium 2025. So my name is Akira Nakagawara, Chairman of the Executive Council, APHOG. So APHOG stands for Asian Pediatric Hematology and Oncology Group and is a clinical study group of childhood cancer in Asia. So APHOG was officially founded in 2021, 4 years ago, but the initial kickoff meeting goes back to 2012, 13 years ago. So Asia is very large and occupies about 60% of world population, including many low and middle income countries where the cure rate of childhood cancer is still very poor. So therefore, APHOG and the SIOP Asia decided to work together to increase the cure rate and better care for children with cancer in Asia, just like two peas of a cat, a Chinese poor. The APHOG also collaborates with the Pediatric Oncology East and Mediterranean, POEM, St. Jude Global, WHO, and other international organizations. The theme of this year is JMML and MDS. So please enjoy the symposium. Thank you. So now Dr. Gevorg Tamamyan, Continental President of SIOP Asia, gives another opening remark. Dr. Tamamyan, please.
Thank you so much. Thank you very much, Professor Nakagawara.
Yeah.
Thank you so much, Professor Nakagawara. It's a great honor and pleasure for me to welcome the participants of this important symposium. Thank you very much for putting this together, this beautiful program, and bringing people around here. I think it's very important to keep this kind of educational event for the collaboration, and I'm honored to be part of it. Thank you very much.
Okay, then let's start. So chairpersons Godfrey.
Okay, yeah. Thanks a lot, Akira and Gevorg, and President Gevorg. So we will introduce the first speaker, Professor Charlotte Niemeyer. So Professor Niemeyer is well known for her involvement in pediatric MDS and JMML. She's from the University of Freiburg, Germany. She is the director of the Pediatric Hematology Oncology Divisions, Department of Pediatric, University of Freiburg. And she's also the executive committee member of the ASH, which is representing the pediatric hematology part. And she will talk about JMML today. So Charlotte, please. Yeah.
Well, thank you very much for the very kind introduction. I will see that I can bring up my slides. Can you see them in the presenter mode?
Yeah, we can see.
Yes.
Okay,
yes,
great.
Quite good.
Thank you very much indeed. And thank you very much for this great invitation. I will talk about the molecular genetics of JMML and the impact. These are my disclosures. My real disclosure is that I'm a part of our European Working Group of MDS, which also includes JMML in childhood. And that's a fantastic cooperation of 20 countries in Europe with national coordinators, reference diagnostic laboratories, and I have the great pleasure to work in our study coordinating center in Freiburg and Ulm, Germany. we have very close contact to our French and British colleagues. So it's really a European effort to understand these disorders. I guess you all know what JMML is. There's a typical clinical picture with hepatosplenomegaly. Often there is respiratory symptoms like cough. The skin can be involved. And on peripheral blood smear, you see leukocytosis with monocytosis and precursors. Most strikingly, splenomegaly is almost often there, but it may not, and it may occur during the clinical course. And 90% of these patients do have either myeloid or erythroid precursors on peripheral blood smear. So it's not only the monocytosis, look for these precursors. In 65% of cases, the karyotype is normal. In 25% it's monosomy 7 and other aberrations in 10%. If you look carefully, you do find very often signs of autoimmunity. You have increased immunoglobulins. You may have a positive antiglobulin test and often anti-nuclear antibodies. Most of us know that the hemoglobin F is very often elevated. It's a hallmark, but in cases with monosomy 7, it's often normal. But you may not know that hemoglobin F is surprisingly stable during the course of the disease. So it's not a sign of progression, or in other words, if you missed measuring hemoglobin F at the very beginning of the disease, you can do it later, and you still have a very important parameter for prognosis. JMML is a RAS-driven neoplasia, and there are 5 major genetic subtypes. 3 of those, PTPN11, NRAS, and KRAS, are somatic heterozygous gain-of-function mutations. And in 2 cases, we have germline disease with biallelic inactivation of the respective gene, and that is neurofibromatosis type 1 and CBL or Sippel syndrome or rasopathy. And you can see here the percentages in our European cohort, with PTPN11 being the most common subtype. Risk factor for relapse after stem cell transplantation and risk factor for survival are highly dependent parameters. And there are 2 clinical parameters, and that is age and hemoglobin F. Age above 2 years is usually a good cutoff for high risk. And although most of these patients have an elevated hemoglobin F, in our series, we find that a hemoglobin F cutoff of 15% is a good cutoff for risk parameter. So patients who have more than 15, hemoglobin F or higher than 15% are high-risk patients. In the small children below the age of 6 months, you cannot evaluate hemoglobin F, but all these kids are low-risk kids being treated like less than 15% hemoglobin F. Then there are genetic risk factors like subclonal mutations, so more than one subclone. And there are epigenetic risk factors like the DNA methylation profile. And I will talk about these 3 risk factors, but you have to be aware of them now in order to understand the genetic subgroups and the impact of the genetics on therapy. I start with PTPN11 mutated JMML, heterozygous somatic gain-of-function mutations in a non-receptor tyrosine phosphatase. And the mutations are in exon 3 or exon 13 of PTPN11. So the molecule shown on the lower right cannot fold together, so cannot be in an inactive state. These children are non-syndromic. They very often have high-risk features, and currently we all transplant these patients to cure them. Now, I show you some unpublished data from our biannual symposium of EVOC MDS and SAA, which was last month in Berlin. And these are data from a young resident, Eduardo Muratore. And Eduardo looked at 224 children with JMML and PTPN11 mutated subtype. And you can see here that only 98% had splenomegaly. So there are some JMMLs at diagnosis without an enlarged spleen, and not all of them had monocytosis at diagnosis. He showed there was a striking relationship between age and survival, and that's shown here. So you see on the very top, the light blue, children below the age of 6 months, then the next curve, 6 to 1 year, and the bottom one, children who are more than 2 years of age. And I show that deliberately because not all PTPN11 mutated JMML is an aggressive disease, as the textbook often says, and we copy and paste from each other. It really depends on the risk factor, and age is a very strong risk factor. The other thing Eduardo nicely showed, that patients with PTPN11 mutated JMML and monosomy 7 are younger, and they have a low hemoglobin F. And you can see that in the plot in the middle on the left side. You see cases with monosomy 7 under yes, and the one above 2 years of age are the purple dots. The other ones are yellow. And on the right, you see no monosomy 7. So monosomy 7 is not a sign of progression. In fact, in this cohort, it indicates a lower risk and an intermediate or low methylation group and an excellent survival, as you can see here. Now, you also know that germline PTPN11 mutations code for Noonan syndrome, an autosomal dominant disorder with great clinical heterogeneity. And you do know that these patients with Noonan syndrome can develop a myeloproliferative disorder at birth or shortly after birth, and that is generally polyclonal, so you don't find any other mutations. But it can look exactly like JMML. There are a few cases who develop monosomy 7, some of them even resolved, and very rarely, there are some cases in the literature when these patients with myeloproliferative disorder develop ALL or a JMML-like picture later. But in the very vast majority, it's a transient disorder, which we call myeloproliferative disorder. It's not a neoplasia, it's polyclonal, and it's transient. There's a huge overlap in mutations between the somatic PTPN11 mutated JMML and Noonan syndrome. So in other words, you have to do germline analysis, and we recommend that for all small children, at least under the age of 2. We often do it in hair or buccal swab. Obviously, fibroblasts are the way to go, but it may be much too tedious. And you would like to know before you talk to the mother or the father whether it's a Noonan syndrome or a JMML. The next subtype is Sippel mutated JMML. CBL or Sippel is a ubiquitinase, and we see loss of function mutations in the linker or in the DKB domain. In most cases, there is biallelic inactivation, so you have 2 changes, one genetic and one acquired, but sometimes you only find one, so it's a heterozygous situation. These patients may have a phenotype, but they don't need to have one. It's overlapping with Noonan syndrome. And often they have 1 or 2 caveolé spots. There's a risk for these patients for arteritis later in life as well, arteritis of big vessels, which includes optic involvement and also moya, or it might also include the big abdominal vessels. Occasionally, these patients have gross splenomegaly. We at APHOG observe all these patients, and they gradually grow out of their myeloproliferative neoplasia. They keep the Sippel mutation, and they keep the variant allelic frequency of that mutation, the acquired one, which is around 50% most often. Now, what I put down here is some more details on germline analysis. We recommend it in all cases, but we think it's mandatory prior to initiation of JMML-specific therapy in PTPN11 mutated disease in small children, when Sippel mutation is the sole operation to make sure it's really a germline disease underlying. The very few patients where you think KRAS or NRAS mutations occur with syndromic features. And for NF1, to make sure it's really germline. But if you suspect NF1 and you have café au lait spots, you probably you don't want to wait till you have that result. You can start with therapy. The tissue I already went into for speedy diagnostic, hair follicles, bucket swabs are often utilized. Now, NF1. The clinical diagnosis of NF1 is a very reliable marker of NF1. So in other words, if you have 5 or more than 5, actually 6 or more café au lait spots with a diameter of more than 15%, or if you have café au lait spots and an effective parent, you can make a sure diagnosis of JMML if you have the appropriate clinical picture. These patients are often older. Sometimes they're even 10 or 12 years old, and the platelet count is often within the normal range. Stem cell transplantation is indicated for these patients. And the NF1 variant molecularly are distributed across the whole gene, and there's often premature protein truncation. And as already alluded to, there's somatic inactivation of the wild type gene. The biallelic loss can be uroparental disomy. It can be a somatically acquired deletion or inactivated variants on the other allele, on the second allele. This is an interesting study I want to show you, which Christian Flotter and colleagues in the lab performed. They looked at the patient with a clinical diagnosis of NF1 in more detail. And if you look at this plot and go to the blue line, you can see that a fair number of these patients have compound heterozygosity, some of them have UPD, and some of them have microdeletions. And then Christian and colleagues looked at the cases we called quintuple negative because we couldn't find a mutation. And he showed that out of these 16 patients, 6 or 38%, in fact, had a diagnosis of neurofibromatosis type 1, or not in all of them was germline available, was thought to have a diagnosis of neurofibromatosis type 1. And you can see here that looking at the blue line again, you don't see the cases with LOH because they're usually picked up on normal regular DNA panel testing, but you have to look for microdeletions and compound heterozygosity. Now, KRAS mutated JMML, these patients are young, medium age is 0.9 years. They can be very, very sick. And they have molecular changes in the typical oncogenic sites. They don't have a phenotype, and sometimes they surprise us with an erythroid predominance. There's an interesting difference in the incidence. We see more KRAS patients with monosomy 7 than you'd see in Japan. I don't know about the other Asian countries, but it's quite striking when we compare our data with the Japanese data. And I will talk about therapy in a second. About 10 to 20% of these patients go into a complete clinical and molecular remission with azacitidine. And we have a growing crew of patients who are off azacitidine in stable clinical and molecular remission up to 5 or 6 years out. There's an overlap with what people call RAS-associated myeloproliferative disease, or RALD. To be very brief, I think RALD is something like JMML without leukocytosis. It also has autoimmunity, often more autoimmunity than what we see in JMML, but I believe there are two sides of the same disease. NRAS mutated JMML, typical oncogenic sites. Most patients are non-syndromic. And here says some patients, but quite a few patients who are less than 3 years of age, who have a low hemoglobin F, and who do not have a blast count above 10% show remission of their disease with time. I'll go into that in a second. Other patients have very aggressive disease, need stem cell transplantation, and relapse after stem cell transplantation as well. The spontaneous remission has been shown first by our Japanese colleagues, and we also could then verify that in our old series. Now, looking at a little bit more in detail in that, and here I'm showing data unpublished from Jolie Deval, a PhD student from Ghent, and her supervisor, Matthias Hoffmann. They looked at 82 NRAS mutated JMML patients who were more than 80 months from diagnosis, and showed that 56 were transplanted, 6 had died, 1 was left to follow up, but 19 were just followed with an observant approach. We had 3 other patients whom we had diagnosed, so they followed 62 patients without the intent to transplant who were alive more than 18 months from diagnosis. And this may be a little bit small to read. Sorry, I have to go back one. How do I do that? I can tell you, maybe if you don't see it, maybe it's small to read. All of these children had a normal karyotype. All of these children had a hemoglobin F less than 15%. And in the methylation array, all of these children were of low methylation. And for many of them, patients, mom came in and said, my kid is not sick. They had splenomegaly, they had the typical hematological findings, but they were not severely affected by their disease. Interestingly, the T and the B cells were involved as well. The patients were followed up to 30 years. As you can see here, or close to 30 years. And the VAF was stable with the exception of 3 patients who came down with their VAF down to 6%, interestingly. But for the remainder of them, it was stable during all the time. And you can see here on the right plot the follow-up, but you can also see, and these are the blue circles, that 2 patients were transplanted early because of progressive disease, and these patients had a blast count more than 10%. That's why I said I would be careful with those patients. And then you can see that 1 patient who succumbed, it's a red X, developed JMML after a complete remission, so kind of relapsed. And 1 patient developed BALL after complete remission for CMML spontaneously. And this patient had basically doubled the RAS mutation. There was biallelic inactivation. So the patients are at risk for BALL, TALL. There are some cases in the literature as well, but the majority of those regain a clinical remission and are stable. So we currently just observe these patients as well. Now, there are some cases reported of clinical pictures of JMML, but underlying fusion genes with ALK, ROS, 51L1, or CDHC886. And in the international consensus classification, we like to call these patients JMML-like rather than JMML. They have a different etiology. They respond to tyrosine kinase inhibitors. We treat them differently. And that's being pointed out in the international consensus classification. You know, there's the WHO classification as well. Unfortunately, we currently have 2. What are the differences? I don't think you have to measure KMN2A as a required genetic test. We already talked about that we call the translocations JMML-like. But the most important thing is, and that's why I put this up here, I do not believe, and that's in contrast to the WHO, that you can make a proper diagnosis of JMML without genetic criteria, without knowing the subtype. Because as I showed you, treatment varies tremendously, and you cannot judge that from the clinical picture. There are rare other diseases who look like JMML, who are transient And one of them is germline biallelic loss of function variants in a gene called SH2B3, a gene which is inhibiting, for instance, JAK2 signaling. And there is some recent literature from our French and American colleagues who looked at the JMML series and found these patients with this genetic disorder. There are also some somatic variants that have been described in other myeloproliferative neoplasia. And I think SH2B3, besides the biallelic germline disease, as a heterozygous mutation, is something like a facilitator for other neoplasia. So secondary mutations, there is a set of secondary mutations, and Elliott-Stiglitz, as well as our French colleagues, have shown that they have some prognostic significance. In our own series, it varies depending what mutation you look at, and we currently do not use that as an additional parameter according to our multivariant analysis. Christoph Lote was the first to show that aberrant DNA hypermethylation is present and characterizes JMML with poor outcome. This was then elaborated on in whole genome DNA methylation by 3 groups. And lately, we have an international consensus definition on DNA methylation between the Japanese, the American, and the European study groups. And high methylation indicates a higher relapse rate post-transplant. And if you can look at the upper right, you can see PTPN11 is often high methylation. You can see NF1 is across the board. KRAS is low or intermediate because of the monosomy 7. And NRAS is very often low, and these are the kids you can watch and wait. CPL is low, Noonan are included here, and they are low too. And monosomy 7 often clusters with KRAS. We will hear more about stem cell transplantation. These are our old data published 2005, and again, age with the prognostic factor for relapse incidence. There are similar data from cord blood, from the Japanese experience, and from our North American colleagues. And just one word, Elliott-Stiglitz and the American colleagues concentrate basically on pre-stem cell transplant procedures and studies, like cytoreduction, RAS pathway inhibition. APHOG instead concentrated on stem cell transplantation and increasing the graft versus leukemia effect. We pioneered azacitidine, and we're currently using azacitidine and donor lymphocytes for patients with high risk for relapse post-transplant. I think I can skip that. That's azacitidine. Azacitidine was approved by the FDA as the only drug for JMML. And the thing to know about azacitidine is it works well in the low-risk patients, but many high-risk patients continue to have progressive disease with azacitidine. I mentioned we do a pilot study with prophylactic AZA post-DLI, which is not without problems because we do see GVH and severe GVH. We currently see it indicated for high-risk PTPN11. And this, I think it's close to my last slide. This is a reminder, going back to the PTPN11 crew of these 225 patients, which Eduardo worked at. And it's the overall survival which is shown here. And what I want to point out is that JMML is rare, so we lump patients over many decades. But fortunately, if you look at these decades, we improve survival dramatically. So we are no longer at 50% for JMML. We are up to somewhere around 70 or 80%. And we have to figure out what is it. Is it different management of GVL? Is it azacitidine, pre or post-transplant? We don't know yet. And that's my summary. I think the identification of the genetic subtype is essential. Age and hemoglobin F above 15% are strong prognostic factors. approximately 20 to 30% of these JMML patients do not require stem cell transplantation, like SIPL, NRAS in certain cases, like KRAS when there's a good response to azacitidine. Azacitidine is the standard of therapy prior to stem cell transplantation in Europe. And I already pointed out, if you have high-risk patients who do not respond, do not delay stem cell transplantation for azacitidine. There is a strong graft versus leukemia effect, which we will have to study and probably hear more about. And methylation classifier and subclonal landscape certainly have a prognostic significance. However, and I didn't show you the data, I'm convinced that you can substitute that in the absolutely most parts by hemoglobin F and H. And I think that's my message also for anybody who lives in countries with less resources. I don't think you have to beat on methylation and you don't have to beat on subclones. If you have patients with poor resources, even doing Sanger for these 5 genes and then do hemoglobin F and you know the age of your patients, I think you can deliver very appropriate therapy for these kids. Thank you very much for your attention.
Thank you for the wonderful comprehensive review of JMML. So because we want to leave all the Q&A at the end, so if you don't mind, stay with us. So I think Professor Haruki will introduce our next speaker, Hideki Muramashu, yes, from University of Nagoya. Yeah.
Okay. Next speaker is Dr. Muramatsu from Nagoya University, graduate school of medicine. He's working with Professor Yoshiyuki Takahashi there. Dr. Muramatsu is the leaders of JML project in JCCG, Japan Children's Research Group. Dr. Muramatsu, can you start your presentation?
Thank you, Professor Hori, for this kind introduction. Can you see my slides on screen?
Now we cannot see, but just before you start speaking,
I see.
Yeah.
I see. I will change. Wait for a moment. Okay. It works?
Yes,
okay.
We can see. Yeah.
Thank you. I'm Hideki Muramatsu from Nagoya University, Japan. Thank you for that great honor for this presentation in this nice symposium. My talk's title is Molecular Pathogenesis and the Planned Clinical Trial of Azacitidine plus Tamamyan. And thank you for the Professor Niemeyer's great talk. So I can skip many slides of my talk. Anyway, JMML is a distinct subtype of MDS-MPN and very, very rare. Only 1 to 2% pediatric leukemia, and in Japan, only 10 to 15 cases, newly cases are diagnosed. And JMML is characterized by hyperproliferation of such abnormal myelomonocytic cells, and mainly under 5 years old young children affected. And these cells show the hypersensitivity to GM-CSF cloning assay. And this is a landmark discovery in JMML from the Niemeyer's nice review in Blood in 2019. And oncogenic KRAS or KRAS were identified in 1991, and NFM identified in 1994, and somatic PTP11 and SIBO. And that in 2013, several works are published using the whole exome sequence analysis. And 2017, 3 papers are published describing the methylation classes of JMML. Of course, RAS-MAP kinase gene mutation is main signaling pathway of the molecular pathogenesis in JMML, and this is a comparison between EVOG European study and Japanese study, and very similar proportions we have. And as Professor Niemeyer presented, the last pathway mutation defined the prognosis of JMML, mainly the PTPN11 and NF1 poor, and NRAS KRAS is middle, and SIBO showed much better. And second genetic events in JMML, 3 paper published using whole exome sequencing, and among one of these papers is ours. And second genetic events, so for example, ZPPN or JAK3, mainly occurred in the PTPN or NF1 clusters. So these secondary genetic events is one of the reasons of the poor prognosis of PTP11 or NF1 mutated JMML. And in 2018, we published in the Blood paper about RNA sequencing and methylation analysis. And our data show that whole genome-wide methylation identified 2 groups of methylation groups, higher and low. And this high methylation is associated with poor outcomes. And 3 groups independently published the same 450K Illumina methylation analysis, and we performed the international collaborative study about the DNA methylation. And again, the 3 methylation subgroups are identified. And very interestingly, as Professor Niemeyer said, intermediate methylation is significantly associated KRAS plus monosomy 7. But in Japan, I don't know why, but that's some geographic or population difference in Japanese or maybe in Asian countries, KRAS plus monosomy 7 is very, very rare. And so in the as a result, intermediate methylation class proportion is very low in Japanese cohort compared to the European or United States. So, using only Japanese cohort, the 2 groups is reasonable. Okay, then after with collaboration with Imaizumi, my younger colleagues, we tried only clinical parameters can predict methylation status or not. As you can see, and this is from the figure from a paper in Blood, the hypermethylation, high methylation classification is significantly associated with known clinical risk factors. For example, exclusive for SIBO or PTPN germline, and are significant associated with NF1 or PTPN somatic or presence of secondary genetic events or higher hemoglobin F or higher age or LIN28B expression, etc. And this is collaborative work with the UCSF, Elliot Stiglitz, and we divided that cohort training and validation cohorts. And using this training cohort, in unadjusted logistic regression analysis which can predict 450K base high methylation or intermediate methylation. Of course, age, hemoglobin F, and the monosomy 7 and SIBO and PTP11 and NF1 and NRAS are significantly associated with significantly associated methylation classes. So based on these findings, we developed a machine learning algorithm which can predict the methylation status. We developed 3 algorithms, and the best work, the decision tree algorithm worked the best. If the PTP mutation positive, we can classify as a high measure, and if hemoglobin not hemoglobin elevated, yes, and age high, it's so only the last pathway mutation plus hemoglobin F and age can mimic the or recapitulate of the methylation classes. And this is training cohort, this is validation cohort. It works well, I think. So the first case report of JMM showing clinical response to azacitidine was published in 2009, a case report with KRAS plus momesamide 7. And then European group published a retrospective analysis of azacitidine-treated JMML. And then 2021, Professor Niemeyer published the APHOG prospective as a study for JMML and treated 18 cases and poor response for high methylation profile, but overall survival and leukemia-free survival in total cohort was exceptionally high compared to the previous historical cohorts. And following this observation, with Japanese colleague, we ran the JMM20 prospective clinical study using the azacitidine monotherapy, 3 cohorts, 3 cycles azacitidine, and assessed a clinical response. And we an ongoing Japanese prospective azacitidine study evaluated the clinical response using the consensus criteria. And this is our results. 36 cases are already registered, and we stopped recruitment in last March. And this is outline of study. Of course, this is in observational period, so I can't figure the Kaplan-Meier curves at this moment. But we observed the misdiagnosis in 3 cases and drop out the study due to institutional policy for 1. But we experienced some relapse. But fortunately, at this moment, 36 cases, no one died. So I believe this prospective study improved the clinical outcomes of JMML in Japan. So using these clinical specimens, we now ongoing performing the biology study, including whole genome sequencing and bulk RNA sequencing, and some with single cell RNA sequencing. And we also applied the wet protein array and in-depth protein analysis and site of single cell RNA and DNA sequencing and error-corrected data. I'd like to present error-corrected sequence data in this presentation later. And this is our paper, our previous prospective study for JMML in Japan. We published in 2024 in TCT journal. This is a stem cell transplantation study using a Japanese regimen, busulfan plus fludarabine and melphalan regimen. And 31 cases are registered, and eligible cases 28. And experienced graft failure and early death, and the engraftment achieved in 21, and continues 18 cases CR, continue to CR. So based on this study, we observed a higher white blood cell count at the stem cell transplantation is significantly associated with disease relapse. And smaller children, body size, body surface area under 0.5 square meter associated with a higher TRM rate. So as a future perspective, tumor burden might associate with relapse and small body size associated TRM. So this is the idea, but anyway, we'd like to, there's a need for minimal residual disease measurement in JMML was. To attack this, we previously published droplet digital PCR methods to detect subclonal JAK3 and ZPP1. And to broad this idea, we tried error-corrected next-generation sequencing technique, because as you know, Illumina short-read sequencing technique, we need to accept 1 to 2% sequencing error. So it's very difficult to use as a MRD assessment. So to clarify comprehensive overview of the subclonal mutation landscape and its prognosis implication in JMML, we performed error-corrected NGS in JMML and NSMPD using 21 gene panel associated with myeloid malignancies. And this is an overview of identified mutation. we identified 130 mutations with higher BRAF and 30 mutations with very low BRAF. And this error-corrected sequence data are significantly associated, showed a good correlation with ddPCR data. And this is a clinical and mutation profile. We observed a lot of secondary genetic events and mainly in PTP11 or NF1 cases. And 30 had secondary mutations. And this presence of secondary genetic events is significantly associated with survival. And RAS W mutation is much more has a power to the outcomes. And this is recaptured from the Professor Kabe's data. And we also performed the colony and Sanger sequence data. Surprisingly, we observed some PTP11 combined with ZPP1, but independently got 2 clones of NRAS. And in this case, first hit is of course PTP11, but then we have multiple NF1 clones. And this is a timeline of this mutation. In this case, we observed a very small subclone before 2 months before the clinical relapse. So we can measure using this method, the MRD in JMML after stem cell transplantation. So we can apply for example, DLI or post-transplant azacitidine or other therapy. So I'd like to introduce our next clinical trial in Japan. So RAS-MAP again, RAS-MAP kinase pathway is very important in JMML. And of course, the Tamamyan is a good candidate drugs for targeting this pathway. And as you know, in last year's Cancer Discovery, the San Francisco group published the clinical trial using Tamamyan monotherapy. And they tried this drug for the 10 cases with RR relapse or refractory JMML and showed a significant number of cases showed a clinical response. And based on these findings, they tried azacitidine plus Tamamyan therapy in vitro and in vivo, and using the JMML model mouse. And they showed the additional effect of azacitidine plus Tamamyan. And they also introduced 2 cases treated with combined therapy with azacitidine plus Tamamyan. One case is very severe bad germline PTP11, and second case is somatic PTP11. And this combination therapy was well tolerated even very, very clinically ill patients, and both patients exhibit objective responses. Following this observation, the COG group started the combined therapy in this prospective study. Now, in Japan, we now planning a new clinical trial, and hopefully we'd like to start next year, azacitidine plus Tamamyan for 3 cycles and assess the clinical response. And we accept any treatment after 3 cycles of chemotherapy. And of course, civil JMML we observed, but non-civil JMML, we basically tried as SCT, but as Professor Niemeyer's presentation, recent observation studies suggest that we may need to adjust our current approach. And so this is a schema of new treatment, azacitidine plus Tamamyan. And the primary endpoint is clinical response rate after 3 cycles. And secondary endpoint is adverse events and overall survival, and the association between response rate and the biological markers, of course, including methylation classes. So this is a proposal. If in a country, a patient with JMML has access to azacitidine and Tamamyan, please consider giving 3 courses of azacitidine plus Tamamyan using the same schedule. And even as an observational study, this would be highly valuable. It could enable future integrated analysis across countries. And this is my last slide. Thank you for your attention.
Thank you, Dr. Pulamatsu. Godfrey, you take a chair.
Oh, yeah, okay.
Okay.
So thank you, Professor Muramashu. Very good, I mean, to introduce a clinical trial in APHOG. I hope many audience in this meeting will be actively involved in this observation study. Okay, so thanks a lot. So we'll leave the questions to the end. So after the comprehensive review of JMML and also a new clinical trial proposal, we know that JMML, the intermediate risk and high risk, need to have transplant. So it's very timely for us to review the transplant experience. And Kirill Kirkivov, I hope I pronounce your name right.
Yes,
from
thank
the Derov Research Institute of Pediatric Hematology and Oncology in Nikolay Balkin National Medical Research Center of Russia, will share with us his experience using transplant for JMML because he has he transplanted a lot of patients with JMML. Kirill, the floor is yours. Yeah.
Thank you so much. I hope you could see my screen. And of course, I'm really happy to represent this work on behalf of our institution in Nikolai Blokhin National Medical Research Center of Oncology, as well as I'm executive director of the Russian Society of Pediatric Oncologists and Hematologists. That's why we are here in APHOG and SIOP Asia. And of course, I would like to pass my regards from our colleagues, especially President of our society, Professor Varfolomeeva. And of course, I'm proud to be a part of EBMT Pediatric Disease Working Party board, because this is one of the most pediatric topic in transplant. First of all, I would like to say that, of course, I'm not a person who is more specifically a hematologist, mostly transplantologist. That's why I'm really happy that Professor Niemeyer and colleagues give a nice overview on clinical options for JMML, and I will say more about transplant features such as regimens and tolerability, such as infections and especially syndromes of sinusoidal obstruction that were kindly mentioned by my colleagues previously. And of course, there is a big difference between countries in our world. Unfortunately, more than 80% of cancer patients are living in low and middle income countries, and of course, it's a big problem to have enough resources for transplantation as well as a basic treatment for JML. And of course, in this regard, we are thinking more how we could improve this. And today, we know that for initial treatment, we require for most of the patients transplantation, and for relapsed cases, we should have our new technologies in transplantation. And I hope that in future, more children will be available to receive transplants in their own countries. And of course, the improvement of studies and the results of the treatment are holding with the years. Professor Niemeyer showed a nice graph with the PTPN11 mutated JMML and the improvement of the results, same as for other cases of leukemias. And I hope that in future we will receive the same good results as for all of the leukemias in the modern era. And of course, we should work more together for example, cure-all framework of WHO to improve the availability of transplant technologies worldwide. Today, we are working mostly in our country with EBMT criterions and indications for hematopoietic stem cell transplantation. And as for other types of leukemias and malignant disorders, we have clear indications for transplantation. Nowadays, for MDS and JMML, We have our standards of care for matched sibling donor transplant and matched unrelated donor transplant, as well as the clinical options for mismatched related donors. Also, there is a mention about auto, but only as some sort of clinical trials, and generally it's not recommended. And of course, I would say that these indications are clear, both for juvenile myelomonocytic leukemia as well as the secondary acute myeloid leukemia for such patients. And of course, as it was said before, more than 80% of patients with JMML will require transplant as soon as possible after the initial treatment. You could see that most of the patients with PTPN11, NF1, etc., required such transplant. And of course, unfortunately, most of the patients have a high risk of high risk profile for disease course. And as it was told before, CBL mutated disease is risk. The risk of CBL mutated disease is generally low, and transplants are rare. So today, before hematopoietic stem cell transplantation, we should care more about the accurate diagnosis, including differential diagnosis with MDS and acute myeloid leukemia, pre-transplant therapy, donor search during this pre-transplant therapy, good infection control with a combination of anti-infection drugs and infection control measures, as well as taking into account non-infectious complications such as syndromes of sinusoidal obstruction mentioned before by my colleagues, and especially in the high-risk groups. The initial thing is that the main idea of donor choice in JMML is in time hematopoietic stem cell transplantation. It means that we should have a good donor search, as well as the availability of databases, both national and international. Unfortunately, you could see that the haploidentical transplants is the clinical options. It means that we should start with match unrelated donor search. And why I've indicated this mismatched unrelated donor is the sign of question is that because unfortunately chronic GVHD seems to be higher in this kind of transplants, because during our analysis we found that, for example, in our cohort, we saw the higher rates of chronic GVHD in total number of leukemias transplanted, for example, from 9 of 10 donors. And also, we should decide on the type of conditioning regimen, because usually it's myeloablative conditioning regimen, but sometimes we could speak more about reduced intensity conditioning regimen. So nowadays, the standard of preparative regimen according to criterions of European bone marrow transplant group is a combination of busulfan, cyclophosphamide, and melphalan. In this regard, we could set this as a standard therapy for a high number of the countries, both in high and low and middle income setting. And of course, there are several discussions on triosulfan-based regimens that showed promising effectiveness, especially in the combination of fludarabine and tiatepa. Here you can see a very nice data from a BMT study for leukemias. There, about 10% of JMML were included, and you could see that the overall survival rate is clear, as well as the toxicity rate is not so high. And of course, not only conditioning regimen itself, but also immunosuppressive therapy, GVHD treatment, and post-transplant therapy is quite important. Unfortunately, several patients still are under or the risk of graft versus host disease. That's why the ideology of early tapering of immunosuppressive therapy is still important, but unfortunately, patients with JMML could facing a severe graft versus host disease, and still about 10% of patients have such risk, as well as a chronic GVHD risk. Also, I would say that the patients with PTPN11 mutations are still under the consideration for DLIs, as well as the other types of cell therapy. And of course, my colleagues already presented this George's idea about trametinib usage for JMML that could be also interesting. Also, I would like to say that, of course, with the years, the risk of GVHD and severe GVHD decreased, and I hope that in future we will fight against this problem. And of course, another problem is syndromes of sinusoidal obstruction or veno-occlusive disorder. Unfortunately, JMML, due to the nature of disease, are in the risk group for VOD arrays. And of course, unfortunately, we should take into account this high risk. As it was mentioned before by my great colleagues, we should think more about this, and in some cases, we should initiate early treatment with difibrotide or prevention and prophylaxis. Also, the discussion on type of conditioning regimens are quite important in the presence of high risk of VOD. You can see, and I will remind you that the clinical picture of VOD presented in the right side of this slide for pediatric BMD criterion, and it's quite important to say that there is no limitation for time of onset of VOD, and you should have 2 or more of the following criterions, such as rising bilirubin, hepatomegaly, ascites, and thrombocytopenia. And also, it's quite important to speak more about the second transplants after the relapse of after the first transplants. This is the great work by Dr. Vinci in collaboration with Professor Niemeyer and colleagues from Japan, explaining the experience of second transplants for JMML, and you can see that the results seems to be quite nice because of the safety and tolerability of these transplants. Of course, the best transplant is not done, then it's not done. So I hope that the new strategies for relapse prevention will be effective. So, as it usually works, how do I? So in our center, we use more triasulfan-based conditioning regimens for the first transplants for JMML. Usually it's triasulfan, fludarabine, and tepa with a dosage presented on these slides. And for second transplants, we use usually intravenous busulfan and fludarabine and melphalan. And immunosuppressive therapy immunosuppressive therapies are different from the donor type. For much related donor, we use ruxolitinib-based therapy with abatacept and rituximab. Much unrelated donor plus ATNG, and in several cases low-dose cyclophosphamide. After transplant, For mismatched unrelated donor, this is ATG plus PTCI, and for gaploidentical TCR alpha beta CD19 depleted grafts, it's usually abatacept, tocilizumab, and rituximab, and for cyclophosphamide depleted gaploidentical transplants, it's usually both rituximab, abatacept, ruxolitinib, vedolizumab, and of course cyclophosphamide. As it's usual, we use immunosuppressive therapy discontinuation as soon as possible based on the BMT recommendations on day plus 40. And for chronic GVHD cases, we use based approach, but there are several new drugs available in our country, like belumosudil and axatilimab. So this strategy, we could say that this is a very nice strategy, we think, but we know that not all these drugs, especially such costly drugs like belumosudil and axatilimab, for example, are available in different countries. We know that the tresulfan is not available in all of the countries, and of course, in this regard, I think busulfan, cyclophosphamide, and melphalan strategy could be very effective. And of course, we have such such a good thing like availability of defibrotide as a prophylaxis for a second transplants with busulfan usage. And of course, it's a big privilege by our government who is paying for these drugs. And I hope that in future, this kind of prophylaxis will be available worldwide. And of course, this is a big problem with much unrelated donors. These donors, we know that sometimes is not they are not available in several countries, and when we spoke with the countries with low and middle resource setting, they said that could be unavailable, but I hope in future this would be available worldwide too. And of course, not all of the patients have much related donor. So like a case presentation about the transplant technologies, I will not say about the mutations, etc. To save several time, I could say that we could show one of our patients with 80-month-old patients with PTPN 11 mutation receiving first transplants from much related donor with our base prophylaxis with ruxolitinib. Unfortunately, at day plus 140, we found a relapse, but it's not only like relapse, it was mixed phenotype acute leukemia, and before it was JMML. So the second transplant were done after pre-transplant chemotherapy with the usage of busulfan, melphalan, and ATG, with the use of much unrelated donor. Why I'm explaining this example as that we use defibrotide as a prophylaxis, we use ruxolitinib, so we are covering the possible incidence of different vessel problems and no signs of VOD diagnosed, as well as the patient have only a febrile neutropenia and pre-engraftment syndrome, and that's all. Patient was engrafted at day plus 13, and I hope he will stay in remission for a long years. So this was an example of how the in time supportive care could lead for a second allogeneic transplant, even in very dense period after the first transplant. And the last thing I could say is about possible options for cell therapy. Nowadays, we are piloting our NK therapy post-transplant study on already 12 patients enrolled. This is most patients with leukemia, but I hope that in future we will enroll patients with JMML too. So this could be a very nice option for a future. At the end, I would say that I'm really glad that now I'm presenting together with such nice professionals and at this seminar. And of course, I am honored to present the data from Japanese team. You could see that I would say that one of more important things is diagnosis, of course, but transplant should be a very important step in this case. And of course, we should give a very accurate conditioning regimen as well as immunosuppressive therapy and graft versus host disease prophylaxis, because each time we transplanting JMML, they think not only for the first transplant, but sometimes for a second transplant. That's why it's quite important to give a window, an option for a second transplant or for good post-transplant therapy, including both azacitidine, DLI, or maybe other kind of cell therapies. In this regard, I would like to thank you for attention, and we'll be happy to discuss more after the completion of this great seminar. Thank you again.
Thank you, Akira, for very comprehensive and complicated conditioning regimen. I'm sure it generates a lot of discussion later on, but we will keep it to the end. So now, after the 3 consecutive talks on the JMML, we will shift the gear to another important aspect, which is the myelodysplastic syndrome. So I have to introduce Professor Henrik Hässli, a long-term friend, Henrik. I remember we met in 1995, it was almost 30 years ago. So he's the pillar of the Gevorg. So I think he and Charlotte basically formed the Gevorg. And then he also is one of the co-founder, the lawful AML group, which also, I mean, generate very good results. So and Henrik has a lot of experience in myelodysplastic syndrome, and he will give us some overview, especially on the genetic aspect of MDS tonight. Henrik, yes, the floor is yours.
Thank you very much for this kind introduction. It's a pleasure to be here together with you in this webinar. I have agreed with Dr. Xiafan Xu that she will present therapy of MDS, and I will focus on the classification and the predisposition syndrome. First, this slide about the frequency of these rare diseases we are discussing today, that MDS and JMML are exceedingly rare, occurring in just 1 to 2 new cases per million children per year, contributing just 1 to 2% of the malignant hematological diseases we see. So MDS is a clonal myeloid malignancy, and it's characterized by this triad of growth advantage of clonal cells. There's a disturbed differentiation and an increased apoptosis. It means that the cells have retained some capacity of differentiation in contrast to acute leukemia, but also an increased tendency to undergo apoptosis, meaning that the bone marrow is not dominated by blast cell, but in some cases quite hypoplastic. And when we look at the cells, then just by morphology, we don't see that many malignant cells, but by cytogenetics or genetics, many of the cells are involved sharing the genetic aberration that is characteristic for the type of MDS. MDS is mainly a disease of adults, but it's very different presentation in adults compared to children. I mentioned the incidence that is very low in children. We often see associated abnormalities, germline aberrations in children. A hypoplastic form of MDS is common in children, in contrast to in adults. When we see cytogenetic aberrations, it's mostly monosomy 7, which is uncommon in adults, whereas we seldom see monosomy 5 or deletion 5q. And then our aim of therapy is always to cure our patients, where that is not always realistic in adult and elderly patients. So the standard of classification has been morphology. It was introduced by the FAB group in '76, and it was a very important tool for communication about this disease. And it was the definition of acute leukemia and differentiation between ALL and AML. And we are still working with morphology, but sometimes it gives us challenges to differentiate between friend and foe. So WHO classifications over the years have gradually made a transition from a classification that back in the 70s was based on morphology to now a genetic basis of classification. The classification is still mainly based on experience in adults, but there has been a recognition of pediatric entities. So JMML is included as a specific entity, as well as the myeloid leukemia of Down syndrome, and the pediatric MDS being subdivided into refractory cytopenia of childhood and refractory anemia with excess blast, as it was called, but now we use the word MDS with excess blast. During the recent years, we have seen division in the classification systems, because there is a publication both from the WHO group and from the International Consensus Classification, ICC. And it has resulted in these two publications from 2022. And also, as mentioned by Charlotte Niemeyer, produced some controversy and confusion in the MDS and AML field. The difference has mainly been about the minimum requirement for blast for making a diagnosis of AML. So the blast threshold have changed over time. In the old FAB group, it was 30% that defined acute myeloid leukemia. In the 2016 WHO classification, it was lowered to 16. But in the most recent classification, it was lowered to 0 in WHO and 10% in the ICC classification, when there were defining genetic aberrations. The lower table here shows the confidence limit for estimating blast count. So if you count a blast percentage of 10% and you count 100 cells, the confidence limit is between 4 and 18%. So quite wide. And it can be narrowed by counting more cells, but still there are some inaccuracy in assessing the blast count, and we should not rely on blast count alone. This algorithm shows one way of approaching the diagnosis, that there are, as seen here on the left, some disease-defining genetic aberrations. These are translocations defining AML, and they may classify a patient as AML regardless of the blast count. In contrast, if you find monosomy 7, it's a strong suggestion that this is an MDS-like disease. There are also genetic aberrations that may be included here, like the NPM1 suggesting AML, whereas UBTF-TD is suggesting MDS. And then, of course, we have the blast count. For MDS, you will always find a low white cell count. Leukocytosis is not in accordance with an MDS diagnosis. And we need, in some cases, to repeat the bone marrow after a few weeks to make a proper diagnosis instead of too early making a diagnosis without all the necessary documentation. In childhood MDS, there are unique genetic aberrations, but there are no such list of MDS defining genetics as in AML. So most of the defining aberrations, they will lead to a diagnosis of AML. And this way of approaching the diagnostic process should identify those patients with a chemosensitive disease that can be cured by chemotherapy. Whereas in MDS, chemotherapy alone is not capable of curing these patients, and they would need a stem cell transplantation. This plot shows characteristic genetic aberrations in childhood MDS. What is found in adults, where mutations in TET2, DNMT3A, or TP53 are quite common. They are very seldom seen in children. Instead, there are some mutations seen more commonly, like ZBP1, AXL1 or 1X or RAS mutations that is typically found in pediatric MDS. But the spectrum of the mutations is very different from what's seen in adults, and less mutations are found. So the other characteristics of pediatric MDS is the frequent finding of germline abnormalities. Here are listed some of the aberrations seen in MDS and in JMML. In MDS, there are a little more listed because there is this different types of inherited bone marrow failures that may all lead to development of MDS. In some, it's quite common, like with Fanconi anemia or severe congenital neutropenia and Shwachman-Diamond syndrome. There's often a development towards MDS. The two most important aberrations found in pediatric MDS are GATA2 mutations or mutations in SEMD9 or SEMD9L. And I will present these two separately. First, I'll just mention Down syndrome, that we know has a high risk of developing myeloid leukemia in early childhood. They are often with a dominance of megakaryoblast in blood and bone marrow and associated with a GATA1 mutation. They are listed in the WHO classification as separate diseases, the one occurring in newborns as the transient abnormal hematopoiesis, or the myeloid leukemia of Down syndrome occurring typically at 1 or 2 years of age, also with a GATA1 mutation. These two diseases should not be considered MDS or AML. They are quite unique, and despite a low blast cell count and dysplasia, it should not be classified as MDS, but treated according to unique myeloid leukemia of Down syndrome protocols, which are associated with a favorable prognosis in these children. So not to be mixed up in any ways with MDS. In this table, a number of the predisposition syndromes are shown with the typical age when they present. We know of many of the diseases that I mentioned earlier presenting in childhood. I just want to mention that there are some aberrations like DDX41 presenting in adults and even elderly adults. So despite being a germline predisposition, it's extremely rare to see in children or even young adults. So I will now deal with GATA2 and 79L, and you can see that GATA2 is typically in children and including young adulthoods, whereas 79 is mostly in young children. Both these two syndromes can be associated with a number of organ abnormalities. So with pediatric MDS, and often the MDS is a standalone without any visible organ dysfunction, but sometimes these patients may have a presentation of lymphedema or different organ dysfunctions that have been present for years before the cytopenia develop. This is especially for GATA2 deficiency, but also for 79 ataxia or other neurological symptoms may be present before the hematological problems are evident. It is now only almost 10 years ago that we described that GATA2 mutations were very common in pediatric MDS. We found that in all MDS, GATA2 germline mutations were present in 7%. But if we only looked at patients with monosomy 7, 1/3 of the patients had a GATA2 mutation. For trisomy 8, there was also a higher frequency of GATA2 seen in 16%. And it was shown that GATA2 was especially common in older patients, in teenagers with a median age of 12.5 years, compared to 4.2 years in other patients with monosomy 7 without GATA2. So as shown in this figure, the GATA2 was extremely rare in the young children, but among teenagers with monosomy 7, 72% had a GATA2 mutation. Looking at the outcome of GATA2-associated MDS, we found that following transplantation, there was a similar outcome regardless of the presence of GATA2. There was a better outcome for those who presented with refractory cytopenia compared to advanced MDS, but comparing GATA2 wild type and GATA2 mutated patients, there were no differences. A recent update on GATA2 mutation, including more than 200 patients, showed a number of interesting findings. First of all, it's worth noticing that there were a few patients without symptoms. These were typically family members identified as part of a family examination because a child has been diagnosed. These asymptomatic patients were often elderly, representing parents of affected children, and some of them had normal hematology and have no reports of any abnormalities despite having a germline mutations. The figure here shows again that GATA2 seldom manifest before 6 years of age, and then the cumulative incidence increases into adulthood, young adulthood. So the management of GATA2 deficiency depends on the states you decide to treat the patient. It is a delicate decision when to transplant these patients. It is possible to do a transplant before any symptoms have developed, or it could be done when there's an MDS with low blast count, or when more advanced MDS has developed. It would be advantageous to do the transplant early in the disease course, because you may use less intensive conditioning regimen and still keeping a good overall survival for these patients. And what we have learned so far is that almost all the patients with germline GATA2 over time will develop pancytopenia and MDS that may progress over time. So now I'll turn to 79L. Here is a historical description of the development and the discoveries. It's a gene that has been known for only the last 10 years, and the last majority present with cytopenia and MDS in early childhood. It was back in 21 that it was described in an APHOG MDS cohort of pediatric MDS to be found in 8% of the patient, and especially among those with monosomy 7. What is a special feature of 79 is that there is a possibility of somatic genetic rescue, meaning that patients with the mutations may eliminate the mutated gene and, for instance, develop uniparental disomy of 7q, and thereby eliminating the disease-causing mutation. And it has been seen in several patients that the presenting monosomy 7 and MDS may disappear over time. It is important to remember that this observation has only been done in younger children. So this quite unique possibility of somatic genetic rescue have impact on the management of these patients, because patients who present at a young age, defined as less than 5 years of age, even despite monosomy 7, they may be closely observed and not sent to transplant. But if they have progressive cytopenia or acquisition of secondary driver mutation, a transplant is needed. But for some of them, they may regress and cure themselves without transplantation. So far, for all the patients we have seen presenting at an age older than 5 years have needed a transplant. So in this situation, a transplant should be planned as soon as possible. So in summary, genetic predisposition is very frequent in MDS, especially MDS with excess blast and monosomy 7. And it is especially SAMD9 and GATA2 present in more than 2/3 of the teenagers with monosomy 7. These findings will impact therapy. And as mentioned, for some patients, the young patients with SAMD9 and monosomy 7, we may observe the patients without transplant. It's important to include a possibility of a germline aberration in the family when we select for donors, and the decision when to transplant is very delicate and should be discussed with the families and at multidisciplinary teams to make a best decision. So that was my last slide. So thank you very much for your attention.
Thank you, Professor Hasney. So I think we have a very comprehensive review of the myelodysplastic syndrome children. Thanks a lot. So we'll keep their questions and answer at the end. I think my co-chair, Professor Tang Yongmin from Hangzhou University, will introduce our last speaker, last but not least, is on the treatment of pediatric myelodysplastic syndrome by Professor Zhu Xiaohuan.
Okay.
Professor Tang, yeah.
Okay, thank you, Dr. Chen, the introduction. And my name is Yongmin Tang, okay, from the Children's Hospital of Zhejiang University, okay, Hangzhou, China. Let me just first introduce Professor Xiaofan Zhu. Dr. Xiaofan Zhu is the department head of the Pediatric Hematology Oncology from the Institute of Hematology and Blood Disease Hospital at the Chinese Academy of Medical Science and the Peking Union Medical College. And she is also the chair-elect of CCCG, and I think it will be soon become the chairman of the CCCG in a few days, in this week, I think. And also, she is the principal investigator of the CCCG 2025 ALL protocol in China. Her main research area is the pathogenesis and the treatment strategies of pediatric hematological disease. She is the recipient of the second prize of the National Natural Science Award and the first prize of the Tang Award Science Award. And she has published many research papers in high-impact journals such as Lancet Onset and JAMA Oncology and Nature Cell Biology, Blood, etc. And Dr. Zhu, today Dr. Zhu will give us a talk on pediatric MDS. Dr. Zhu, please.
Thank you for Professor Tang introduce me, and thank you, Professor Henrik, for switching the order with me. Good morning, good afternoon, everyone. I would like to thank the conference for giving me the opportunity to share our study on treatment of pediatric MDS. Today, I will focus on treatment of RCC and advanced MDS, as well as present data from our center, pediatric MDS cohort. In March 2010, we held a conference on pathological section consultation with pediatric hematologists and pathologists from Japan in Tianjin, China. The experts from both countries exchanged the clinical data of 50 cases of children and diagnosed the bone marrow morphology and pathologic specimen respectively. Consensus was reached after discussion. In terms of different differential diagnosis, the degree of hyperplasia, the degree of cytopenia, reticular count, and the MCV were helpful for different essential plastic anemia from RCC. This slide shows our RCC treatment approach guided by cytogenetic and transfusion stage. Standard risk patients are observed if transfusion independent with hematopoietic stem cell transplantation, reserved for those who developed transfusion dependence or significant neutral pair. High-risk patients such as those with monosomy 7 or complex karyotypes proceed directly to hematopoietic stem cell transplantation as the definitive curative operation. Together with pathologic expert, we reviewed the analysis, the clinical data, and the pathological section of children with cytopenia with visit our hospital from 2001 to 2021. Eventually, 184 children were diagnosed with RCC. The median follow-up time was 7 years. Decided on whether the patient required red blood cell or platelet transfusion at their initial diagnosis. We divided the patient into the transfusion-dependent group and the non-transfusion dependent group. By analyzing the baseline clinical feature of the two groups, it can be observed that the megakaryocyte dysplasia in non-blood transfusion dependent patient is more significant. The treatment for transfusion dependent group included intensive IST, cyclosporine, androgen, and hematopoietic stem cell transplantation. Among them, stem cell transplantation is the most effective with response rate of 75%. The overall response rate of IST was 70%. The response rate of IST was related to the response rate in the first 3 to 6 months. In other words, patients with poor response to IST treatment should consider stem cell transplantation treatment as soon as possible. The treatment of the non-blood transfusion dependent group, including cyclosporine, androgen, and observation, there was no significant difference in the response rate among the different groups. In other words, for patients who don't rely on blood transfusion, the use of immunosuppressing and hematopoietic stimulating treatment doesn't significantly increase the response rate. For this group of patients, treatment approach of observation and waiting might be more appropriate. As RCC is a subtype of child MDS, we also analyze its clone progressing rate. The progression of clone include transformation into AML, advanced MDS, the emergence of PNH clone, and chromosomal abnormalities. With a median follow-up 98 months, the 5-year cumulative incidence of cloning progress was 3.2. cloning progressing significantly reduce the survival of a patient. The presence of monosomy 7 at the time of initial diagnosis was associated with a high risk of clone progressing. For patients we were not transfusion dependent at the initial diagnosis, the cumulative rate of progressing to transfusion dependence within 5 years was 18.7%. Patients with megakaryocyte dysplasia at the initial diagnosis had increased risk of progressing to transfusion dependence later on. Treatment of advanced MDS in early year. The APHOG MDS 9-8 earlier year study represent one of the largest pediatric MDS cohort. Hematopoietic stem cell transplantation achieved a acceptable but not satisfactory outcome in advanced disease with 5 years overall survival of 63%. However, once MDS progress to AML, prognosis become extremely poor. This slide summarized the baseline characteristic of our center advanced MDS cohort. In total, we include 72 patients diagnosed between September 2011 and April 2022. Among them, 54 patients were classified as MDS-EB and 18 patients as MDS-EBT. The median age of the cohort was 80.5 years, and 2/3 of the patients were male. This slide shows the mutation landscape of our 72 patient pediatric 72 pediatric MDS patient. 18% of patients carried germline mutation. 79.2% had a somatic mutation, and 63.9% had 2 or more gene mutations. Importantly, RAS or MAP pathway mutation was the most frequent, present in 45.8% of patients. Highlight their central role in pediatric MDS. This was different from the somatic mutation subterm in DOT. In DOT, MDS mutation in RNA-16 gene predominate, occurring in approximately 64% of cases. PTP11 was the most frequently mutated gene, account for 18%. This slide shows the baseline feature of the 16 patients with PTP11 mutation. This slide shows the baseline features of the 16 patients with PTP11 mutation. 2 patients carried double PTP11 mutation. All varied were missions except for one India. The most common hotspot was amino acid 7614 in 33% mutations. Stem cell transplantation significantly improved survival. The 2 years old OS was 90% and only 26% respectively. Similarly, the 2 years EFS was 68% and 27% respectively. This result highlight the stem cell transplantation provides a substantial survival benefit and play a crucial role in treating pediatric MDS. The necessity of pre-transplantation treatment, including the methylation therapy, low-dose chemotherapy, and chemotherapy similar to that for AML, remain controversial. Here we present the outcome of 30% advanced MDS patient undergoing hypomethylating agent treatment of chemotherapy at our center between December 2007 and April 2022. 53.3% were MDS-REB and 46.7% were MDS-REBT. All 3 patients completely at least 1 cycle of treatment, with 30% of them receiving more than 1 cycle. Among the 25 patients who respond to 1 cycle of therapy could be evaluated, the ORR was 60%. Specifically, 16% of those patients achieved CR and 28% achieved CRi. Additionally, there was no significant difference in ORR between the different groups. Moreover, 76.7% of the patients underwent hematopoietic stem cell transplantation. All the condition regimen used were myeloablative, and they were all modified beside on the BUCY regimen. Multi-round analysis indicates that hematopoietic stem cell transplantation and pro-transplant transplant overall response as a predictory of better OS. We found that children with bone marrow blast and 50% before transplantation had improved OS and EFS, indicating that reducing tumor burden before hematopoietic stem cell transplantation can provide improved prognosis. Finally, I would like to share the result of single-center pediatric MDS hematopoietic stem cell transplantation among 27 high-risk pediatric MDS patients who underwent hematopoietic stem cell transplantation. Nearly all received induction therapy before transplant, with 19 achieved blast below 5%. The stem cell cells were mainly haplo-related donor, and the cord blood all received myeloablative condition. At median follow-up of 26 months, the 3 years overall survival was 84.8%. We have recently updated the data again. It can be seen that the proportion of cord blood as a source of donors has increased, encouraging the 2 years OS exceeding 98%. This slide shows the result of transplantation therapy for 10 cases of GAT2 deficient. Patient received myeloablative BU/Y beside conditioning with 5 days of disturbing, and the stem cell source include haplodonor, fully matched sibling, and cord blood. All patients successfully engraft after 18 months of follow-up. All patients remain disease-free. In summary, our understanding of pediatric MDS has allowed considerably over the past 4 decades, so classifications still largely follow WHO standard. Pediatric MDS share some genetic and molecular feature with adult disease, but also present unique pattern for non-transfusion dependent RCC patient observation. Abuse may be suppressive to immunosuppressive and hematopoietic stimulating treatment. Currently, hematopoietic stem cell transplantation remains the only curative option for those children. Thank you for your attention. At the same time, I also want to thank our bone marrow failure disease team and the experts who have helped and collaborated with us over the years. Thank you.
Yeah, thanks a lot, Professor Tu, for sharing. So Professor Tang and me will now chair the Q&A sessions. Because of the shortage of time, probably we will just limit it to a few questions. For those audience who would like to ask questions, you can use the Q&A box. If you don't have time to answer some of the questions, at least our speaker will be more than happy to answer it in written form. Okay, so I think one of the most important things for tonight's meeting or symposium is the East and West kind of exchange. So it's very good that we have Professor Niemeyer and Professor Hesney here to share with us. I think can first, Professor Niemeyer, with the European and also your position in Asia, you know, the COG kind of approach, comparing to what Professor Muramashu and Akira, proposed kind of transplant and the treatment approach. Charlotte, what will be your suggestions and then any comments so we can improve on that? Charlotte, are you still? Yeah.
Okay. If I understand,
I know this is a long question, but
no,
I hope that you can give us some opinion. Yeah.
If I understand you correctly, you're pointing out to the different approaches currently, and what I think, where we could be going from here. I think one thing is, and we will see, we have a xenograft mouse model, and we believe that it works, and that before you go into a clinical trial, you should see what happened in the mouse. And in the mouse, we do not see any advantage of something like trametinib or any of the drugs on top of azacitidine. So we are kind of reluctant to go for combinations right now because azacitidine works on the stem cell and we can't see any additional effect there. So that's one big question. What is the role of trametinib? Personally, I'm not convinced of it. If I look at the US data, I'm not convinced. Our mouse data say the contrary. So we will figure out what trametinib in the addition of azacitidine does. That's one big question. Another big question is, can you, for the patients which you watch and follow, can you get them into a molecular remission? Because looking at the NROS cohort, and it's a big cohort where you just watch and follow, we will see some B-ALLs, we will see some T-ALLs, and the VAF in many patients stays high up. So is it smart to follow them if in the end we have 20% likelihood of getting acute leukemia? We don't know that yet. That's another big therapeutic question. And then on top, and this is my last question, I think we are, or not a question, it's a statement, I think we are up for big surprises in JMML because Hideki, like we, have patients with KRAS and monosomy 7 who go into remission, but suddenly come back with monosomy 7 only, without KRAS. And looking at single cell data, monosomy 7 was first. So do we really understand JMML? Is it really true that the disease defining is the RAS mutation? Are we missing something very big here? So I think it's a very interesting enterprise for all researchers who come after us. We will find out many more things. So whatever we do, I think it's a world which we put together because it fits so nicely, but I'm not sure whether it's true.
I think
this is my comment to your question.
Yeah, thanks a lot. I mean, actually, we are looking forward to more collaboration in the future because Asian, as mentioned by Akira, we have the number, but we have to unify, our approach to answer a different question. So the next question is with Henrik. How about the treatment for MDS after you listen to Professor Zhu's approach? Any comment on the MDS treatment?
Thank you. That was a nice presentation, and I think there are many similarities between the approach presented and the one we have been using in APHOG MDS. We have also shown that observation in a number of the patients presenting with refractory cytopenia of childhood is appropriate. Some of them remain stable and transfusion independent for years, and some show spontaneous improvement over time. And for those who have transfusion dependency, immunosuppressive therapy may be indicated in some of these patients. For the patients with MDS with advanced disease, excessive blast, we do agree that transplant is the treatment of cure for them. There may be some discrepancy between the need for pre-transplant chemotherapy in our approach, and also presented by Xiaofan Xu, that we did publish data showing no benefit of pre-transplant chemotherapy before transplanting MDS excessive blast. I think there's still an open discussion there. It may depend a little bit upon how you do analyze the data, because I think the most important is to look at what was the highest blast count before transplant. And that count is with a reflection of the disease. and it definitely will impact the outcome. If you transplant earlier in the disease, the outcome is better. And I'm not so persuaded that we can change that by giving intensive chemotherapy before the transplant.
Yeah, thanks a lot. So I think because Professor Tang, my co-chair, you may have some questions, right? You can ask the last question, but before Professor Tang, I saw some Q&A box with some question. Please, our speaker, if you see that, you can answer that in the written form. Professor Tang, you have any questions?
Yeah, thank you. Just to talk about the transplantation for the patients with either JMML or MDS, I think this is very important. You know, for most of the patients, I think the transplantation is necessary, since transplantations can be a curative, can be cure of these diseases. And I would like to ask Dr. Kirill, okay, from Russia, okay, and talk about a lot of about the transplantation. Since especially I wanted to ask what kind of donors you wanted to choose. You know, first since the haploidentical, I saw you in the slide in the, you are talking is 45% of the patients being transplanted with the haploidentical donors, right? So if yeah, of course, you know, for a child, most of the patients haploidentical, the parents is available in all the time almost. Okay, so if there's no other you know choice, or maybe they still have some optional for the allogenic or cord blood, and what kind of you know donors do you want to choose for those kind of patients?
Thank you so much. So fortunately, we have a growing national registry for unrelated donors. That's why we are trying to identify initially much unrelated donor from the registry, as well from, of course, from abroad. And if the time is long, or if the donor is not optimal, for example, female of 9 of 10s with a lot of pregnancies, we could still use haploidentical donor. But we are trying to use this BMT guidelines and first to try much unrelated donor. Concerning cord blood, unfortunately, we don't use we didn't use it for last 10 years, I think. But of course, I could not say that this option isn't working at all. But if potentially we want to use donor lymphocytes infusion or to produce NK cells, and NK cells, cord blood is not very comfortable, because we could not use DLI from cord blood, of course.
Okay, thank you. I have another question for Dr. Zhu Xiaofan. Okay, Dr. Zhu, are you here? Can you hear me?
Yeah.
Yeah. I noticed that you talk about the RCC by using the immune suppressor therapy to treat. I would say in the are you worried about the if you use since you know the RCC is also a kind of MDS, right? So there's a malignant clones may exist in this kind of patients. So if you try to use the immune suppressive therapy for those patients, are you concerned about the you know the development of the leukemia, you know, also like that? Yeah, just how about you?
Myelodysplastic cone, yeah.
Yeah, yeah.
我用中文回答你吧。
可以，I translate to English.
那个因为我觉得在日本小岛教授考基玛教授他们曾经做过这样的研究，就是在 RCC 的病人里边，就是用免疫抑制治疗，其实他认为是效果是相当的，但是我觉得是
Wait a minute. I just translate first. because
Okay.
Professor G mentions that she followed the advice of a professor from Japan and saying that in this group patient is also helpful. Right? Continue.
但是我想那是就是很早年以前，但是随着现在对这个疾病的认识哈，我觉得它的治疗其实还是有不同的结局，就是从本质上来讲，它的发病它并不是一个免疫机制介导的，所以目前我们认为，如果是非输血依赖的病人，用这些免疫抑制或者是造血刺激治疗，其实它的效果是不令人满意的，所以还不如等待观察。一旦发生输血依赖的时候呢，那我们造血干细胞移植更能够根治它的这样的一个疾病。
So I summarize it very quickly. So Professor G saying that this is the formal data. So with all the accumulations of latest data, so now I think for the non-transfusion dependent refractory anemia, usually you should not use the immunosuppressive therapy. And whereas in those patients with even with transfusion dependent situation, early transplant probably is a better choice. So I think because of running time, the time is running short. So I will pass the summary to Professor Shinsuke Hirabayashi, and then our SIOP Asia immediate past President Hiroki Hori will also give the closing remark. So first, Professor Shinsuke Hirabayashi.
Can you hear me?
Can you give
sorry,
a brief summary?
No, please, sorry, but I'm instead of Professor Atsushi Manabe, so unfortunately he couldn't attend this meeting. Sorry. So, but I got his message, so I read his message. Okay.
Yes,
so
yes.
he said, I'm so sorry that I couldn't participate in this important conference. And APHOG is even more important today because it finally launched new clinical trials, including a novel treatment for JMML, which is still difficult to cure. I'm sure that the treatment plan presented by Dr. Muramatsu is ambitious but comprehensive, and all the audience were attracted with this plan. I hope the APHOG members will discuss this treatment plan thoroughly, and this trial will be started shortly. So I also thank Professor Niemeyer for giving us a simulating talk as usual. So I know that she will visit Japan soon, and I'm impatient for her to come. So finally, I thank all, he said, I thank all the people who organized today's conference by Atsushi Manabe. Thank you. Thank you very much.
Thank you, Professor Shinsuke. So the floor is yours, Professor Hori.
Yes. Hello, everyone. I'm Hiroki Hori, a member of APHOG and SIOP Asia. Thank you very much for attending the APHOG and SIOP Asia Joint Scientific Symposium 2025. Today's symposium was a valuable opportunity to learn about the latest findings in JMML and Pediatric MDS through excellent presentation by experts. APHOG is currently planning an international clinical trial for JMML across Asia, and we hope this symposium will serve as a driving force for moving this project forward. At the closing of this symposium, I would like to thank the moderator and speakers. I look forward to seeing you all again next time. Thank you very much.
Thank you. Thank you.
Okay,
We
thank you.
also would like to thank the SIOP International Secretariat, Suzanne, for supporting us. So, Professor Akira, you have anything to say before we close?
To say it's enough.
Okay.
It's
So
okay.
hopefully, Charlotte and Henrik, we can collaborate more in this very interesting and complex field. Sure, we will have more contact in the future. Okay?
Thank you very much.
So
Okay.
thank you.
It's
Okay,
well
thank you.
taken.
Bye.
Okay, thank you,
Very
everybody.
much.
Thank you.
Bye.
Bye.
Thanks a lot.
Bye-bye. Bye-bye.
Bye.
Thank you, Susan.
Yeah.
Thank you. Bye-bye.
Yeah, thank you very much.
Bye-bye.
No, you're welcome.
Yeah.
Thank you.
Bye-bye.